Key messages of my talk today are that higher volume hospitals do better for elective and emergency care for aneurysm repair and carotid endarterectomy, and that through that services could be reconfigured to improve patient outcomes. The relationship between volume and outcome in major vascular surgery exists for both aneurysm repair and carotid endarterectomy, and it's been shown that a 3% reduction in mortality between the highest volume hospitals for elective aneurysm repair and the lowest volume hospitals, and similarly for carotid endarterectomy there's around a 35% reduction in the odds of mortality between the lowest volume hospitals and the highest volume hospitals, and these relationships remain significant after adjustment for patient demographics and comorbidities. High volume hospitals perform better at vascular surgery because it's a systemic effect of the intensive care, having an emergency department that's set up for emergency presentations, having specialist vascular wards, having intensive cares that are used to dealing with vascular patients, having vascular specialists, anaesthetists. It really is the whole package. If you don't have to refer someone to a different hospital for dialysis, if you can get it on site, and then that's been shown independently to improve outcome. So there is an effect of individual surgeons as well. Practice makes perfect. The more cases you do, the better you get at them. But it's putting the right surgeon into the right environment and treating patients within that environment that leads to the best outcomes. The UK results for major vascular surgery are definitely worse than elsewhere in Europe and Australasia. There are a number of reasons for that, and the first may be due to the way the care is configured with our devolved system of care. There are also clearly case mix differences. We operate on larger aneurysms, on older patients who have a greater number of cardiac and renal and respiratory comorbidities. So there are a number of factors, but we shouldn't underestimate the impact of service configuration. We need to ask patients what they want from the attributes from the service. And a study has been performed whereby a patient focus group was taken, and they told us a number of factors they wanted to be investigated, and these were then given to patients who attended aneurysm screening, so males aged 65 attending a screening appointment. And they showed a very strong preference for access to minimally invasive surgery, to hospitals that do more than 50 cases a year, and to hospitals that can prove safety and can deliver surgery at a low mortality. And these were, they showed a much stronger preference for those aspects as opposed to waiting lists or car parking and various other aspects. Over the next 5 to 10 years, I think there's going to be a sea of change in the way that vascular services are configured. At the moment, we still run on a very devolved system with 242 vascular centres. Radical models of service configuration have been suggested, whereby maybe only 48 vascular hubs are needed across the country. And this will require the formation of very robust referral networks with a number of regional spoke hospitals or local spoke hospitals referring to regional hubs. Now, how the operating is performed at those hospitals, whether the consultants keep ownership of their own patients, is down to local agreement, but I would see these hub and spoke networks being the real core for service reconfiguration. And the models that have been suggested have shown significant improvements in outcome through reconfiguration. Furthermore, in regionalised models of care, patients are more likely to access endovascular treatment, which we know gives a lower early and mid-term mortality. And with the increasing use of endovascular treatment for ruptured and urgent cases, we should be really be able to drive down the mortality of aneurysm repair across England.